Good evening, everybody. Tonight we're going to be talking about the Medicare Shared Savings Program. Next. Here's the agenda for tonight. First, we're going to talk about a little bit overview of the program. Then we'll talk about some limitations and results, and then finally finish it off with some implications of the program. So the Medicare Shared Savings Program is a voluntary program encouraging healthcare providers and suppliers to join together in an accountable care organization aimed at incentivizing value-based outcomes for Medicare beneficiaries. The primary goal of the Medicare Shared Savings Program is to provide high quality coordinated care to improve outcomes and reduce costs. The MSSP was created in 2012 under the Patient Protection and Affordable Care Act and has been ever evolving and changing to react to the current climate in the healthcare industry. The MSSP has its origins in the Physicians Group demonstration project that was funded under the George W. Bush administration. In order to participate in the MSSP, a provider must already be a part of an accountable care organization. An ACO goes away from a fee-for-service type of billing and encourages more of an all-encompassing payment method. The ideas of this new payment method are to reduce redundant procedures for the patient and streamline the healthcare process. Providers are encouraged to invest in areas that provide a patient with high quality and efficient services. Next.
So from a financial standpoint, the main key here with the Medicare Shared Savings Program is that accountable care organizations, which I'll explain in just a moment, benefit financially from meeting certain cost containment and quality outcome thresholds and are held financially responsible if they are not able to meet those thresholds. So the way it works is that participating accountable care organizations, they're able to qualify for shared savings bonuses from the Centers for Medicare and Medicaid or CMS, depending on the degree to which they're able to reduce costs on a per patient basis. Their bonus eligibility does depend on their limit to spending for their patient population at or below a certain financial threshold. An important thing to note is that this does not necessarily eliminate the fee-for-service structure, but rather represents a shift away from volume-based incentives and instead is intended to reward cost containment and high quality outcomes. So the key here is really shifting from volume to value. In terms of thinking of, what even is an ACO, an accountable care organization is a network of physicians, hospitals, and healthcare providers who work together to provide a coordinated experience for patient populations in terms of providing efficient, high quality care while sharing parts of the population's financial and medical risk. I think the risk sharing is really a keynote feature of the program. There's meant to be a strong focus on primary care services at the base of the ACO, meant to promote preventative care measures and ideally avoid healthcare that could be prevented with strong primary care. And of course, reimbursement payments are tied to quality improvement and reduced ability to contain costs. In terms of participation, it is contingent on first being Medicare enrolled, so already supporting a population of Medicare patients, and then the organization can either form or join an existing ACO and then must apply with CMS and become accepted to the program. CMS currently offers two main participation tracks under the program that differ in their respective amounts of financial risk and savings potential, basic and enhanced. The basic track essentially gradually phases in financial risk for all participants after 2 years of participation in the program. There's a 5-tiered structure based on the degree of risk and potential upside that a healthcare organization is willing to incur. And important to note is that the basic structure no longer offers a sort of one-side arrangement with no downside risk. So previously, between 2013 and 2018, the MSSP offered 4 different tracks with differing levels of risk sharing. Tier 1 or track 1 involved no downside and really only offered rewards to hospitals and ACOs that were able to come under certain spending limits per patient. That has since been eliminated in 2019. Now you can either opt for basic or enhanced. Enhanced really involves a more immediate and substantial shared savings losses, shared savings and losses, and is really a higher risk, higher reward structure.
So when talking about a program population, we mainly focus on providers and patients. Providers may include such as specialists, physicians, surgeries, hospital, and other healthcare providers. As we said previously, they have the incentive to cooperate to form an NCO, and they can reduce barriers by sharing information between those entities, so the lack of information can be solved. And also the ACOs may request Medicare claim information about their patients from CMS. And this kind of participation is voluntary. You need, for the providers, they may sign in to a certain agreement period, but they can still to choose to whether to extend it or choose different tracks, different levels to participate. And for the patients, well, you don't need to do anything to participate into this kind of ACO because all depends on your providers. So you cannot choose to opt in or out. But for the data sharing, well, you can choose to opt out of the data sharing, but the CMS may still ask for a certain kind of limited data sharing for improvement in quality. And there will be an exceptional for a patient who cannot join our ACO, because if he joined a kind of Medicare Advantage plan already, Medicare Advantage plan is kind of a private company offering you a contract with Medicare. So it's, for example, it will be like the HMO or the PPO. So if a patient is already inside this kind of plan, you cannot join ACO. Next.
The key aims of the Medicare Shared Savings Program are realizing better health for people and populations, and reducing the growth in healthcare expenditure. In the MSSP program, providers of healthcare must choose an ACO they want to join, and they share in medical and financial responsibilities in the group to realize better patient care without increasing spending. The program encourages beneficiaries, promotes evidence-based practice, and allows internal and external reporting to guarantee providers achieve the cost and quality metrics they have established as part of an ACO. Medicare Share Savings Program is meant to address issues concerning the cost of healthcare and its quality. Healthcare providers who are part of an ACO are held accountable for different aspects as the quality and cost and experience of care. Additionally, it motivates health facilities and professionals to focus on delivering the highest standards of care inexpensively without relying on patient volumes. However, the programs faced considerable difficulties during the COVID-19 pandemic. Doctors' practices and healthcare facilities have experienced a 20 to 60% decline in revenues due to the COVID-19 protocols. According to physicians and hospitals, they're starting to pay attention to patient volumes and increase earnings. Next.
The COVID-19 virus has been the largest limiting factor for the shared savings program in reaching its desired goals. This includes virtual limitations with quality measurement, as well as ability to forecast and receive larger volumes with less quality. And in 2020, we're expecting to see an increased percentage of ACOs subject to risk. So increased risk is also a large factor and limitation. Aside from COVID, just the transparency of data has been disputed, and some insights indicate that increased expenditures are occurring over the period from 2018 to 2019. Additionally, different demographics of the country are very different, and it's hard for one program to cohesively tackle all of those differences. And in the graph on the right, you can see that places such as Florida have much higher spending than the average of the country. Lastly, the requirement of ACOs is also a limitation of the program, which has the unintended consequence of incentivizing consolidation and increasing collaboration of providers and different players in the healthcare industry. Despite these limitations, there are still results that will be discussed on the next slide.
Great, thanks. So in this slide, we want to discuss 3 of the key findings and results from the shared savings program, starting with the spending reduction in physician group ACOs. So in 2015, physician group ACOs had spending reductions that constituted a net savings of about just over $250 million. And these cost savings came from reductions in ER visits, inpatient care, post-acute care, home health care, and outpatient care, just to name a few. And so when comparing that to savings, or the lack of rather, of hospital integrated ACOs, those did not produce savings on average. So spending reductions there were offset by bonus payments, and there were no significant differential changes in any spending categories. When talking about the Pathways to Success program, which was a redesigned program for entering ACOs, this was implemented in December of 2018 under the outgoing administration. So in 2019, we had 541 ACOs in MSSP that generated almost $1.2 billion in total net savings to Medicare. It was the largest annual savings for the program to date, and the 3rd year in a row of net program savings. One thing that's interesting to note is that historically, ACOs in rural areas have realized smaller cost reductions than in urban areas, but under Pathways to Success, rural ACOs have actually improved their performance, and that gap is a lot smaller. And finally, wanted to touch upon the impact of COVID-19 and the potential impacts it will have on future results. So MSSP adopted policies to mitigate unexpected financial impact of the COVID pandemic, giving ACOs relief on quality reporting requirements and supporting providers. CMS has also removed costs associated with episodes of care for treatment of COVID-19 that include inpatient admission. One thing that we wanted to note, though, that's kind of a negative is that no new providers can apply to MSSP in 2021, which guarantees at least a short-term shrinking of the program.
Awesome. So quickly running through some future considerations and implications of Medicare shared savings and ACOs. We actually found a lot of experimentation being done at the state level with Medicaid ACOs, because Medicaid is a state-run program. There's just a lot more opportunities for states to kind of customize implementations of ACOs to meet their individual needs. Currently, 12 states have expanded ACOs to their Medicaid population, with a bunch of states considering rollout in the near future. There is also the application of ACOs in the commercial space. So around 19.1 million Americans with private insurance are actually currently covered under ACOs. So definitely some future iteration and experimentation to watch there. And then something that we found very interesting was the potential to integrate non-medical services within ACOs. So some examples of that would be behavioral health, dental, family services, social services, really looking at patient outcomes holistically, and the opportunity to utilize ACOs as vehicles to provide, a wider variety of care to patients.